Okay, good afternoon, everyone. If you all want to be seated, we'll get started. So I want to welcome everyone to ASCO's 53rd annual meeting. I'm Dr. Richard Schilsky. I'm ASCO's Senior Vice President and Chief Medical Officer, and you're going to be seeing a lot of me over the next few days. I'll be moderating most of the press briefings over the course of this meeting, and I just want to thank you all for joining us here in Chicago, and thanks to those of you who are listening online. We're looking forward to a great meeting. This year's meeting is expected to bring together at least 38,000 attendees from all over the world. As you may know, typically about half the attendees at the ASCO annual meeting come from outside the U.S., so it's a very international meeting. As the largest clinical cancer research meeting every year, ASCO features important and what we hope to be practice-changing research, and you'll hear about that today and over the course of the next several days. So over the next 5 days, we will highlight research that spans the entire spectrum of patient care, from prevention and diagnosis to treatment and survivorship. And we're excited to share with you the year's most promising advances in cancer care, all relating to this year's theme from our president, Dr. Dan Hayes, Making a Difference in Cancer Care with You. We're going to hold 4 research briefings featuring the most significant advances being presented at the meeting, one of which will feature ASCO's keynote speaker, Dr. Siddhartha Mukherjee. That'll be tomorrow at 11 a.m. As you know, he's the Pulitzer Prize-winning author of The Emperor of All Maladies, and he'll be discussing his current book, The Gene, and he'll be focusing on that in the context of many of the targeted therapies and precision medicine advances that you'll be hearing about at the meeting. Of course, he'll also be speaking in the opening session of the meeting on Saturday morning, so I would encourage you to attend his talk. There are also 2 additional press briefings scheduled, one on Saturday afternoon that'll highlight important new partnerships between ASCO's CancerLink, the FDA, and the National Cancer Institute. And then a second briefing on Sunday highlighting the Society's worldwide efforts to connect the global cancer community through a comprehensive portfolio of international programs aimed at improving cancer care for patients around the world. And of course, being mindful of the fact that most of the global burden of cancer in the decades ahead will be occurring outside of the United States, in fact, outside of most of the developed countries of the world. So this is something that ASCO is very concerned about. ASCO has paid a great deal of attention to, and something that increasingly we'll be highlighting at our meetings. Now, today's briefing will feature 6 presentations that offer new insights that address the psychosocial aspects of patient care, survivorship, and quality of life. And frankly, I think one of the themes that binds all of these presentations together to a great extent is that we take pride in the fact as oncologists that we treat patients, we treat people with cancer, and we care not only for them, but for their caregivers, their family members, their support systems. So, I think what will be highlighted here today is the importance of treating not only the patient, but their support network, and focusing on not just the disease, but all of the manifestations of the disease, the impact of the disease on their well-being. Joining me today on the panel are several ASCO experts, Dr. Don Dizon, Dr. Joshua Jones, and Dr. Tim Gilligan, and I'll be turning to them periodically throughout the briefing today to provide additional context about the highlighted studies. When you write your stories, we would ask that you please use our ASCO titles for the purposes of attribution in your coverage this year. So without further ado, I think we'll get on with things. Our first presentation today will highlight the long-term results of a randomized phase 2 clinical trial of a psychological intervention to reduce the fear of cancer recurrence in survivors of cancer. So please join me in welcoming Dr. Jane Baith, a medical oncologist at the University of Sydney in Australia, who will present the results of her research.
Thank you for that introduction, and thank you for giving me the opportunity to present the results of our trial on behalf of the CONCA-FEAR authorship group. Oops. With improved survival from cancer, there's been more focus on survivorship, and in particular, in more recent years, on fear of cancer relapse. Fear of cancer relapse is associated with a poorer quality of life, greater distress, lack of planning for the future, avoidance of or excessive screening, and greater healthcare utilisation. We know that 50% of cancer survivors will have moderate to high or clinically significant fear of cancer relapse. We know that this can persist over the whole trajectory of their illness and out over 6 years since diagnosis. Our group developed a novel theoretical model on why fear of recurrence can be heightened, and that the average patient goes through a cancer experience, has distress, and then comes out with a normal new. Where some patients who have unhelpful worry beliefs or focus too much on the cancer have heightened fear of cancer recurrence. And we then developed a novel intervention to try and address some of these issues in trying to modify their fear of recurrence. This was a lot based on metacognition. So what is metacognition? Metacognition is worrying about worrying. So for instance, a cancer survivor will worry, if they don't worry about the cancer coming back, that it won't be caught earlier and they'll have a worse survival. So we started a randomised trial where patients were randomised to the CONCA FEAR is what we called our intervention, or taking it easy. Therapists were recruited from around Australia and trained in a one-day course. Participants who were early breast and colon cancer or melanoma survivors from 2 months to 5 years post-diagnosis, breast cancer patients could still be on hormone treatment, were recruited. Participants had a baseline survey and had to have on the clinical significant fear of recurrence on that survey. We had 222 patients who were randomised to intervention or control. Follow-up was done after the intervention at 3 and 6 months. So the treatment arms were CONCA-FEAR, where what they did was address their values clarification, so trying to get people to work out what was important to their life and to plan for the future, also to focus on the moment, also to control over attention focus, and the main thing with metacognition, what to worry about and what not to worry about, and how to modify unhelpful thoughts about worry. And it was also developing an appropriate follow-up, that they actually didn't avoid follow-up, and they actually had appropriate follow-up as well. The taking it easy arm, we decided that we would have an actual active intervention, because relaxation technique have actually been shown in previous studies to have effect on cancer patients in anxiety and depression. Each received 5 sessions over so they had 5 60 to 90 minute sessions over 10 weeks, and the therapist delivered both sessions. The results showed participants in both groups improved on all outcomes. The CONCA-FEAR was better than taking it easier on the primary outcome of fear of cancer recurrence in the inventory at all time points, at post, 3 and 6 months. The severity of fear of cancer recurrence was significantly better immediately after and at 3 months, but not at 6 months. Our secondary outcomes included anxiety, cancer anxiety, quality of life, and metacognition. CONCA-FEAR improved all these secondary endpoints compared to taking it easy immediately after treatment, that these were not significant at 3 and 6 months, so potentially did not have a clinical significant effect on these outcomes. So, new treatments for increasing survival from cancer. Fear of cancer recurrence is a real issue. This is one of the first studies to show a new benefit from a new psychological intervention. In the future, we'll do economic evaluation and also explore more accessible and less costly formats such as online, group or community interventions. Thank you.
Great. That's right. Thanks so much. Just to remind everyone, we're going to hold all questions until after all the presentations have been completed. But at this point, I'm going to ask my colleague, Dr. Dizon, if he has any comments he'd like to offer on the presentation.
Yeah, I think I applaud Dr. Beeth for her trial, particularly because we as oncologists, we only have about 15 minutes with our patients, and the assessments for our patients, even in follow-up, for the most part, concentrate on cancer-related outcomes, because that's what our patients want to know. They want to know that they're fine, or they want to know, is their cancer back? When they leave their room, we all assume that there is a level of fear of recurrence that everybody has. And I think we as a community accept that as normal. What Dr. Beeth is showing you is that this is a real entity. Fear of recurrence is a real phenomenon in patients treated for cancer, and it can last out to 6 years. The importance of recognizing that in our communities, not only to say it's real, because our patients love to hear that it's not just in their minds, but because we can do something about that. If we can't do an intervention like Conquer Fear, we can at least tell our folks now, based on this data, that something as simple as recommending relaxation techniques can improve their lives now. But I agree with Dr. Beeth. We need more interventions, and we need to recognize that there are things that our patients go through after cancer that are real, that are significant, and that can not only impact their lives, but also the lives of their families.
Thank you. Thanks, Don. So I think we'll go right on to our next presentation, which you'll see has a similar theme, but perhaps at the opposite end of the spectrum of the cancer journey. So our next presentation will discuss results from a randomized clinical trial exploring a psychotherapeutic intervention to alleviate distress in patients with advanced cancer. And Dr. Gary Roden is the lead author. He's head of the Department of Supportive Care at the Princess Margaret Cancer Center in Toronto. Dr. Roden.
Thank you very much. Yes, I'm going to tell you about the results of a randomized trial we've done of an intervention that we've developed really over the last 10 years. It's been a labor of love, and it's focused on people with metastatic and advanced cancer. And the term managing cancer and living meaningfully, or the acronym CALM, refers to the fact that the intervention addresses both the practical problems that people face, and there are many. How do I manage my pain, my symptoms? But also the profound problems and issues that people face. What is the meaning of my life that having a terminal diagnosis brings? Now, although these problems and challenges with metastatic and advanced cancer, cancers where people might have a prognosis of 12 to 18 months, although these issues and challenges are predictable and cause a lot of distress, there hasn't been a routine or systematic approach to help people with these problems. And so we've developed a novel psychotherapy to alleviate and prevent distress and to help people manage these difficulties. It's relatively brief, at least in the world of psychotherapy, 3 to 6 sessions. It's delivered by trained therapists, and it supports reflection in 4 broad domains: symptom management and communication with healthcare providers, treatment decisions, all the changes in self-concept, how we feel about ourselves when we have a disease which affects every aspect of our physical being and our life, and the changes in relationships, our need to depend on other people, for example, when we have a progressive disease. The sense of meaning and purpose in our life, that's something we all need to think about, but having a disease which creates a prognosis of 12 to 18 months heightens that dilemma, and helping people deal with fears, concerns about the future. So, as I've said, the participants in a study like this are patients with advanced cancer. These are adults fluent in English without cognitive impairment. They were randomized either to the intervention with usual care or to usual care alone. And depressive symptoms measured by the PHQ-9 were the primary outcome, with a variety of secondary outcomes, and we had assessments at baseline, 3 months, and at 6 months. 3 months being the primary endpoint. And what we found is that we had a significant effect on the primary outcome at the primary endpoint, depressive symptoms at 3 months. And these effects were actually strengthened at 6 months. Now, in terms of the meaning, what is the significance of that reduction? We found that there was a clinically meaningful reduction in depression in 52% of the CALM group compared to 33% of the usual care group, and in 65 versus 35% at 6 months. And that's greater than 5 points on this scale of depression. We also found that not only did it treat depression, but it also had a preventive effect, so that participants who were not depressed at baseline were less likely to be depressed at 3 months. And there was a variety of secondary outcomes which also favored the intervention. The extent to which people felt they could talk and feel understood about the impact of cancer, manage feelings about the cancer in the future, communicate with their healthcare team and the family, deal with challenges in their relationships, clarify their values and beliefs, and prepare for the end of life. So what do we conclude? That CALM appears to be an effective intervention that alleviates distress in people with advanced or metastatic cancer and helps them to manage the profound and the practical problems that they face. We found that there's great generalizability to this intervention. We've now trained people in more than 20 countries, including in Europe, in the Middle East, in Asia, and in South America. And we're now in the process of establishing a global network to train health professionals, including oncologists, doctors, nurses, psychologists, psychiatrists, in delivering CALM and evaluating its effectiveness and feasibility in all of the geographic settings that we heard are represented at this meeting and beyond. So thank you.
Great. Thanks so much. So I'm going to ask again Dr. Dizon if you have any comments to try to offer some more perspective on this presentation.
Yeah, I think, congratulations again, Dr. Roden. Just like we have embraced this concept that palliative care is important along the cancer continuum, particularly for patients who are living with disease that is not curable, I think this data just adds much more importance to the concept of paying attention to patients' symptoms beyond cancer-specific outcomes, that we can do things to improve their quality of life, and that patients who are facing advanced disease still need our help. So again, congratulations. I think this is a very important work.
Great, thanks. I'm really glad to see that you're in the process now of establishing this global network to be able to deliver this intervention around the world. As I mentioned at the start, of course, cancer is very much a global problem. I hope it's not lost on those of you in the audience that if you look at the studies being presented today, we've had one from Australia, one from Canada. I'm about to introduce one from Switzerland. We'll have one from the UK and then 2 from the US. So the issues that are being addressed by these researchers truly are issues that affect cancer patients all around the world. So with that, our next presentation features findings from a randomized trial of a web-based stress management program to improve quality of life for patients with newly diagnosed cancer. So we've had cancer survivors, fear of recurrence, cancer patients that approaching the end of life, concerns about what that means for them and their families, and now patients newly diagnosed with cancer, obviously concerned about what lies ahead for them. And the lead author of this is Dr. Vivian Hess, a medical oncologist at the University Hospital of Basel, Switzerland. Dr. Hess.
Good afternoon. It's a pleasure to present our trial, Web-Based Stress Management for Newly Diagnosed Cancer Patients. Diagnosis of cancer elicits high levels of distress, which negatively affects physical and mental health. Furthermore, distress can lead to diminished treatment tolerance and compliance. From randomized controlled trials, we know that cognitive behavioral therapies are effective in alleviating distress. However, the majority of cancer patients lack psychological support due to both barriers on the patient side and lack of resources on the provider side. That's where the internet comes in. 70% of cancer patients use the internet primarily to seek information. From randomized controlled trials in non-cancer patients, it seems that internet interventions, especially in the therapist-guided format, are as effective as face-to-face interventions in a number of psychological conditions, including anxiety disorders and depression. We therefore designed a therapist-guided online stress management program specifically for newly diagnosed cancer patients and aim to assess feasibility and efficacy in a randomized controlled trial. Patients who started their first-line cancer treatment within the last 3 months were eligible. They were randomized in a one-to-one fashion to the intervention or the control group, stratified according to baseline distress. The intervention consisted of 8 online modules with information, exercises, and downloadable audio files. There was a weekly written feedback with our team of psychologists through an integrated chat function. Primary efficacy outcome was quality of life as measured with the FACIT-F questionnaire after the intervention at T2. During the follow-up period, patients from the control arm also gained access to the STREAM program. 129 patients with a median age of 52 years were randomized. The majority were women. And 71% were diagnosed with breast cancer. Other cancers included lymphoma, gynae, and GI cancers. So let's see what happened after the intervention and jump directly to the efficacy results. In the figure in the center, you can see that quality of life improved markedly in the intervention group. Increase in total FACIT-F score was significantly higher in the intervention group than in the control group by a mean of 8.59 points, which is statistically significant and clinically relevant. Let's look at distress on the left here, where we see a very similar picture. Decrease in distress was significantly larger in the intervention group than in the control group. However, changes in mood, here on the right, were not different between groups. In conclusion, our online stress management program was feasible with newly diagnosed cancer patients during active treatment. We were able to reach cancer patients via the internet. The majority of patients were women with breast cancer treated for localized disease. At baseline, 3 in 4 patients were highly distressed, so we reached the target population in need of support. Last but not least, the intervention worked. The therapist-guided online program significantly improved quality of life and lowered distress. Thank you.
Okay, that was terrific. So I'm going to put Dr. Dizon on the spot once more, but he's used to being on the spot. So, Don, anything to offer?
I wore a special tie just for it. So I think this complements the first 2 quite well. Now we have a randomized trial looking at something, again, most oncologists, primarily when we're meeting patients for the first time and starting on curative intent therapy, it is assumed there is a level of distress that people have. But I think, and I would welcome thoughts from my panelists here, but we assume that that level of distress will fall naturally as we start them on therapy. What Dr. Hess is showing is that 3 out of 4 have, not only do they have distress, but it's significant distress. Trying to then stratify or trying to get these patients support can be an issue because they're at our cancer centers quite frequently for medical therapy. Trying to squeeze in then psychological expertise into their treatment plans can become difficult. And I think utilizing an online system has not only been shown to be feasible, but the promise of being effective as well is quite grounded now in an evidence-based randomized trial. So I think this is work, again, showing an unmet need, agreed, but also that there are interventions that can be effective and more that need to be tested.
Great, thanks, Don. I hope we can return to some of these issues, once we get into the questions, because, it seems fairly clear that what these three presentations highlight to a great extent, we're again talking about the experience of patients at the beginning, the middle, and near the end of their cancer journey, is that to a great extent for a cancer patient, this is true for many patients with serious illness, but for a cancer patient, every day is another unknown. And those unknowns create lots of anxiety. And I'm sure it's well known to you, of course, and what sort of illustrates this in somewhat stark contrast was the announcement just the other day from Olivia Newton-John about the recurrence of her breast cancer 25 years later. So these concerns about what lies ahead in the cancer journey and how that impacts patients and their quality of life and how they cope with those concerns effectively is really a lifelong issue for most cancer patients. So hopefully we'll come back to some of those discussions and the questions. So we're going to switch gears a little bit, and our next speaker will present the results from a phase 3 clinical trial comparing single-dose radiotherapy to multiple doses of radiotherapy for patients who have spinal cord compression from metastatic cancer, a very common and oftentimes disabling complication of cancer. The lead author is Dr. Peter Hoskin, who's an oncologist at the Mount Vernon Cancer Centre in Middlesex, UK, and he will present the study.
Thank you, and thank you for the opportunity to present this study, which is a comparison of two radiation doses, a single dose and a multi-fraction dose delivered over 1 week for these patients with metastatic spinal cord compression. So as we've heard, spinal cord compression is a common complication of metastatic cancer. We see 4,000 to 5,000 cases a year in the United Kingdom, and the majority of those patients are treated with radiotherapy. A small number will have surgery for specific indications, but the majority receive radiotherapy. The indications for radiotherapy being to improve neurological function, to maintain mobility, and to relieve pain. And there's no standard radiotherapy schedule. A whole range of radiation doses are used internationally, from single doses of 8 to 10 gray, ranging up to 4 weeks of treatment, delivering 40 gray. So we conducted this trial to show whether a single dose of radiation was as effective as multiple doses without compromising patient outcomes. The trial design was a prospective randomized trial. It was a non-inferiority design, and ultimately we randomized 688 eligible patients. They were stratified by radiotherapy center, the ambulation status at randomization, primary tumor type, and whether patients had extraskeletal metastases as well as skeletal metastases. One-to-one randomization, the control arm was 20 gray, delivered over 1 week, 5 fractions, and the investigational arm was a single dose of 8 gray. We measured ambulatory status, bladder and bowel function, adverse events, and quality of life, and these were undertaken at baseline 1 week, 4 weeks, 8 weeks, and 12 weeks post-randomization. Ambulatory status was categorized by an objective 4-point scale. You see here categories 1 and 2 were patients who were ambulant with or without walking aids. Category 3 was patients unable to ambulate but still having some power in the lower limbs, and Category 4 were patients with flaccid paraplegia. Bowel and bladder function was simply dichotomized to normal and abnormal, and adverse events were scored by standard scoring scales, RTOG and CTCAE. So here you see the headline results. This is the ambulatory status at 8 weeks, which was the primary endpoint of the study. If you look at the right-hand column, you'll see that in terms of conventional significance, none of these time points was any change in neurological function statistically significantly different between the single dose of radiation and the weekly 5 fractions. We look at those patients who presented with ambulation, patients who could walk at presentation. You see here absolutely no difference between a single dose and a week of treatment, and approximately 2/3 of those patients being enabled to maintain their ambulation. The overall positive response at 8 weeks, the number of patients who could walk was 73% and 69%. Again, statistically non-significant. In terms of the non-inferiority design, the defined lower limit for non-inferiority was minus 11%, and we're just approaching that in the difference between the risks. So in conclusion, a single dose of 8 Gray is as effective as 20 Gray and 5 fractions for a range of clinically relevant endpoints, in particular ambulatory status, both at 8 weeks and indeed at all time points between 1 week and 12 weeks. In terms of overall survival, and I've not presented the data, but also in terms of bladder and bowel function, retreatment rates, and adverse events. It shows that early diagnosis is important for best outcomes. Patients who arrive ambulant with either a single dose of radiation or multiple doses will retain their ambulation in almost 70%. And a single dose of radiotherapy, in our minds, is now recommended in this setting, has major advances for these patients. The important thing to realize being that these patients have a very short survival. Their median survival in this study was only 13 weeks. A single dose has enormous advantages in those patients with very short survival times, and of course it is increasingly cost effective. Thank you.
Thanks so much. Lots of important implications to this study. So to offer some comments, I'd like to turn to Dr. Jones on the panel and see what he has to say about it.
Thank you, Dr. Shulsky. Thank you, Dr. Hoskin. This really is an important study. The effects of spinal cord compression can be truly devastating for patients and for families. And we have traditionally used longer courses of radiotherapy requiring patients to come in each day over a week or 2 or 3 or 4 weeks. And this is the first study that really shows equal outcomes in terms of meaningful benefit for patients with a single dose of radiotherapy versus a much longer course, allowing patients to spend more time with their family, more time doing the things that they want to do. So this study looked at 700 patients. A large number of patients really showed tremendous benefit. You know, this came up for me even last week where a patient who wanted to get to a graduation tomorrow would still be receiving radiotherapy, but instead is done and is starting to feel better and is able to get to the graduation. So we still have work to do to figure out for patients who live longer than this average of 3 months, what is the most appropriate regimen. But for many patients, this is going to provide tremendous benefit with the idea that sometimes less really is more.
Great, thanks. So it'll be interesting to see how widely this change in practice is ultimately adopted. I think that's going to be the key thing to keep an eye on. All right, let's go on to our next presentation. As usual, we have another good news story from the pediatric oncology community. The next presentation will feature findings from a large analysis of 30-year trends in the late effects of treatment among childhood cancer survivors. The lead author, Dr. Todd Gibson, is an assistant member at St. Jude's Children's Research Hospital in Memphis, and he'll present the study.
Thank you. Good afternoon. It is my pleasure to present on behalf of my co-authors listed here our study on temporal trends in chronic disease among survivors of childhood cancer diagnosed across 3 decades, which is a study from the Childhood Cancer Survivor Study. Survival rates after childhood cancer have increased dramatically over the past 50 years, such that currently more than 83% of children diagnosed with the malignancy will survive at least 5 years. This has resulted in a growing population of childhood cancer survivors, which was estimated to number 420,000 in the United States in 2013, and which is expected to exceed 500,000 by the year 2020. However, the aggressive treatments required to cure children of their cancers in many cases also increases their risk of serious health conditions later in life. This is evidenced by the fact that more than half of survivors will develop at least one severe, disabling, life-threatening, or fatal chronic health condition by the age of 50. Accordingly, oncologists have made great efforts in recent decades to modify treatments with the goal of trying to maintain high cure rates while reducing the risk of these devastating late effects such as chronic disease and death. However, the impact of these modifications on late outcomes in survivors is not yet well established, and so the goal of our study was to examine whether changes in treatment over time have been translated to improved late health outcomes in survivors of childhood cancer. To do this, we utilized data from the Childhood Cancer Survivor Study, or CCSS, which is a federally funded retrospective cohort of children diagnosed with cancer between 1970 and 1999 at one of 31 contributing centers around the United States and Canada. Survivors were eligible for CCSS if they survived at least 5 years after diagnosis and were diagnosed with one of the common childhood cancers listed here: leukemia, lymphomas, central nervous system malignancies, Wilms tumor, neuroblastoma, or soft tissue or bone sarcomas. CCSS collected detailed treatment data using medical records from participants and also followed survivors over time to collect a wide range of outcome information, primarily via questionnaires. Among the 23,601 survivors included in our analysis, the median age at last follow-up was 28 years, and the median time since diagnosis was 21 years. The main outcome in our analysis was the 15-year cumulative incidence of severe, disabling, life-threatening, or fatal chronic conditions. And we examined these within groups of survivors that were separated by the decade in which their cancer was diagnosed and treated. So to interpret this, in the top part of this slide, you can see that in survivors who were diagnosed between 1970 and 1979, 12.7% of them went on to develop at least one severe, disabling, life-threatening, or fatal chronic condition between 5 and 15 years after diagnosis. Among survivors who were diagnosed in the 1980s, this proportion dropped to 10.1%, and it declined further for those diagnosed in the 90s to 8.9%. In addition to looking at survivors overall, we also looked within specific diagnosis groups. Those are shown in the plot here on the lower part of the slide, where we've plotted the 15-year cumulative incidence again, with the black diamonds representing survivors treated in the 1970s, the red squares, those in the 1980s, and the blue triangles, those in the 1990s. As you can see, we saw significant decreases in the incidence of serious chronic conditions in survivors of acute lymphoblastic leukemia, astrocytoma, Hodgkin lymphoma, non-Hodgkin lymphoma, Wilms tumor, and Ewing sarcoma. Furthermore, when we looked at the types of chronic conditions experienced by these survivors, we saw that the reductions overall were driven by large decreases in the incidence of second cancers, endocrine conditions, and neurological and gastrointestinal conditions. Finally, we also wanted to examine whether these decreases in the incidence of serious chronic disease in survivors was mirrored by decreases in the treatment intensity that they received by decade of diagnosis. To do that, we plotted graphs such as shown here, where on the left y-axis you can see we plotted again the 15-year cumulative incidence of these serious chronic conditions represented by the red dots in these figures. And then we've overlaid on that a treatment intensity score, which is essentially a way to visualize the relative intensity of treatments that survivors received, whether they were diagnosed in the 70s, 80s, or 90s. And those are represented by the black box plots in these figures. In general, we did see that the decrease in the cumulative incidence of serious chronic conditions was mirrored by a decrease in treatment intensity over time, and that's shown nicely here in these examples for survivors of Hodgkin lymphoma, astrocytoma, and acute lymphoblastic leukemia. In conclusion, in CCSS, we found that more recent survivors of many childhood cancers have reduced incidence of serious chronic disease later in life. These changes were correlated with temporal changes in treatment, and this demonstrates that the strategy of trying to reduce the intensity of therapy with the goal of reducing the occurrence of late effects, along with the changes in improvements in screening and early detection that occurred over the same time frame, have in fact translated to reduced incidence of serious late morbidity and improved late health outcomes in survivors of childhood cancer. Thank you.
Great. It's always good to be inspired by the progress that our colleagues in pediatric oncology continue to make decade over decade. So I'd like to turn to Dr. Gilligan, one of our ASCO experts, for some comments and put this study in some context.
So I think it's important to recognize how huge these findings are. I'm an adult oncologist, and so I would look at these findings in some ways as a parent. And if you said to me, my child has cancer, and the good news is we can cure your child, but the bad news is they're going to be plagued with health problems for the rest of their life as a result of those treatments, that's actually bad news. It's bad news for my child. It's bad news for the whole family. It's bad news for me. And so the fact that we're not only seeing increased cure rates, but we're seeing a decline in the problematic health complications that can occur from cancer treatment is really huge progress. These are children's lives that are being affected in very important ways, such as reducing the risk of getting another cancer that's much harder to cure than the first cancer. I live in the adult oncology world. We're often talking about having 6 months of chemotherapy to live another 3 months. There are a number of patients who decline such treatment because they don't think it's worth it. So cure is a huge endpoint. It's really very exciting to see this. And I think it's a reminder of the importance of clinical trials. Part of the reason pediatric oncology has done so well, partly the biology of the disease is different, but also the proportion of patients, pediatric patients with cancer who go on trials is much higher than the adult world. And this is what federal funding of cancer research does for us. It enables clinical trials of new treatments that are less toxic, and it also pays for trials like this that actually follow outcomes so we can see whether we're getting better over time. So it's something to celebrate, and as Rich alluded to, those of us in the adult oncology world are envious of our pediatric colleagues.
Yeah. Thank you, Tim. That was great perspective. So to round out this presentation, in a sense, sort of almost following naturally on the good news in pediatric cancer survivorship, of course, another group where we have a remarkable long-term survivorship are survivors of testicular cancer. To present the findings from a study investigating the incidence of low testosterone and related health complications in survivors of testicular cancer, I'm happy to introduce Dr. Mohammed Isam Abu Zaid, an assistant professor of medicine at Indiana University, the hotbed of the cure of testicular cancer in Indianapolis.
It is my pleasure to stand here today and present on behalf of my colleagues on the Platinum study some of our findings of this study of testicular cancer survivors with focus on hypogonadism and associated adverse health outcomes. Testicular cancer is the most common cancer in young men. Today, 95% of all testicular cancer patients are cured of their disease thanks to cisplatin-based chemotherapy that Dr. Lawrence Einhorn discovered in 1974, that the addition of cisplatin to the treatment regimen back then achieved a significant improvement in the cure of this disease. Nowadays, testicular cancer survivors can expect to live for over 40 years from the time of their diagnosis. However, they are at risk of other health problems that may be related to their cancer treatment, including late complications from chemotherapy. The Platinum study is an ongoing multi-center study of North American testicular cancer survivors. Obviously, its name stems from cisplatin, and the aim of the study is to investigate the major health problems in testicular cancer survivors and understand how and why they develop, with the goal of preventing them and minimizing the burden of cure. Today, I'll be presenting an analysis from the Platinum study looking at the problem of hypogonadism, or low testosterone levels. Men with hypogonadism may suffer from decreased energy, depressed mood, decreased sexual desire and performance, as well as night sweats. Hypogonadism is also a major risk factor for metabolic syndrome, which is a cause of cardiac disease. Our goal is to identify clinical and genetic factors that may help us better predict which survivors are at increased risk of developing hypogonadism. Hypogonadism is defined in the study as a total serum testosterone level below 3 nanograms per milliliter, or the use of testosterone replacement therapy. We also want to see if the survivors with hypogonadism are more likely to have other medical problems associated with it. This analysis includes the first 491 survivors participating in the Platinum study. All participants received platinum-based chemotherapy. They completed comprehensive and validated questionnaires and underwent a brief physical examination. They provided blood samples and their testosterone levels were measured. They also had their DNA analyzed. Of the 491 survivors evaluated in this study, 38% had low testosterone levels or were taking testosterone replacement therapy. Please keep in mind that the majority of these survivors are still young, with an average age of 38 years. Older survivors were at higher risk for hypogonadism, as shown in this figure. In addition, survivors who were overweight or obese were more likely to have lower testosterone levels. Genetic variations in the 6-hormone binding globulin gene appeared important in defining the risk for hypogonadism. However, this finding needs to be confirmed in larger studies, including the next phase of the Platinum study. We investigated the association between hypogonadism and 15 different medical conditions. We found that testicular cancer survivors with low testosterone levels, when compared to survivors with normal levels, were at least 3 times more likely to have high cholesterol, almost twice more likely to take medications for hypertension, erectile dysfunction, or diabetes. They were also more likely to take medications for anxiety or depression. So to summarize, testicular cancer survivors, especially those treated with chemotherapy, are at increased risk for hypogonadism, a problem that can be associated with predisposing factors for heart disease. Increasing age and weight are associated with lower testosterone levels, and genetic factors also appear of importance in cancer survivors, and their role needs further investigation. In conclusion, there will always be the potential for late complications from curative platinum chemotherapy. Mitigating approaches are the usual weight control, exercise, and monitoring blood pressure and cholesterol levels. We will never omit cisplatin from the treatment regimen to prevent complications, but recognizing and treating symptomatic hypogonadism can improve quality of life and lessen adverse health outcomes, especially those related to the metabolic syndrome and resultant diabetes, hyperlipidemia, and early cardiac problem. I would like to take this opportunity to thank the National Cancer Institute for their sponsorship of the study and all the survivors participating in this study. Thank you.
Okay, thanks very much, Dr. Abuzaid. So I'm going to ask Dr. Gilligan for a few reflections on this study, and then we're going to open the floor for questions.
So again, an important study. I think it sends a loud message to those of us who take care of testis cancer patients, and that is my area of expertise, that we need to watch for hypogonadism. We need to ask our patients about it. We need to examine them thinking about it. And in patients who we are worried might have hypogonadism, we need to do blood tests for testosterone and other hormone levels. These are young patients. They have many years of life, so it's many decades of suffering from consequences of this if it's undetected. It wasn't a surprise to me. I feel like I've been seeing this in my clinic, and I was kind of wondering why no one had taught me to look for it, and I figured it out in some ways on my own because I found a surprising number of patients who had symptoms of it, and we tested them, and they are hypogonadal, so it's out there. But I hope this study will get that message out there more broadly, because I think those of us who do a lot of this have been trying to teach fellows to watch for it already. But I don't think it's widely understood among oncologists and other doctors who take care of these patients. The 38% number is higher than previous studies, but I don't think the important point is whether that number is exactly right. This is a larger study, so you need to take it seriously. But even if it's a lower number, it's affecting a significant number of patients. I think we have to be cautious, though, and make sure that people don't misunderstand and think that this means that we should test testosterone levels in all patients, which is a risky thing to do because the definition of normal testosterone is really very fuzzy. There's a wide range of normal, and what's normal for me may not be the same thing as what's normal for another man. So looking for symptoms is really what guides this work, and when there are symptoms, then testing is important.